Good afternoon, everyone. Welcome to our Global Symposium series with Dr. Alfonso Fasano speaking for us today on dystonia and pain management. My name is Alana Dillon. I'm an Education and Support Services Coordinator at Parkinson Society BC, and I'll be facilitating our webinar today. Before I introduce Dr. Fasano, I'd like to go through a few housekeeping items with you. First, I want to let you know that we are recording this webinar, and it, along with the presentation slides, will be available on our website. And secondly, you'll see a chat icon at the bottom of your screen. If you click on that to open it, you can type your questions for Dr. Fasano in the chat box, and he will address the questions at the end of his presentation. And finally, to optimize your experience with this webinar, please ensure that you adjust your speaker volume, both on your computer as well as on your actual speaker, so that you can hear the webinar well. It is my pleasure now to introduce Dr. Alfonso Fasano. Dr. Fasano is author of more than 180 papers in international journals with peer review. He graduated from the Catholic University of Rome, Italy in 2002 and became a neurologist in 2007. After a 2-year fellowship at the University of Kiel, Germany, he completed a PhD in neuroscience at the Catholic University of Rome. And in 2013, he joined the Movement Disorder Center at Toronto Western Hospital, where he is the co-director of the surgical program for movement disorders. He is also an associate professor of medicine in the Division of Neurology at the University of Toronto and clinician investigator at the Krembil Research Institute. His awards and honors include the Andrea Bocelli Award for Young Investigators from the European Federation of Neurological Societies in 2009 and Best PhD Thesis Prize at Catholic University in 2012. Dr. Fasano, welcome. Thank you for joining us here today, and I'll pass it over to you now.
Okay, thank you very much for this invitation. It is always a pleasure for me to talk to people with Parkinson's and their family and their caregivers, and it's particularly nice for me to talk with you from BC today. Unfortunately, I'm not there. I'm a big fan of BC, and I was trying to when I have time to go and to come there and enjoy the many good things that you have there. And I know a lot of people in Canada are pro BC against Toronto, or the other way around. I try to take advantage of both worlds. So as you heard before, my name is Alfonso Fasano. I'm an Italian neurologist. I'm practicing in Toronto, in Canada. Obviously, it's been a few years now, and I deal with Parkinson's disease at the stage when advanced therapies is mainly used and needed. So I happen to see many people with dystonia and pain, which is, as you see soon, relatively common in Parkinson's. So these are my disclosures, and I highlighted here the ones that might be related to what I'm going to say. These are companies with interest in treatments for dystonia and pain. But obviously I try to be as unbiased as possible. In Toronto, we have a patient advisory board besides working with Parkinson's Canada and Parkinson's Canada different provinces, we have developed our own patient advisory board at Toronto Western, and together with them we organize events like this one, which is focusing on deep brain stimulation. The next event is on December 8th. It will be 6:30 Toronto time, so a little earlier for you. And this is an event we put together particularly for people who already had DBS and want to share their stories. We just did a very successful one with more than 250 attendees on what to know about deep brain stimulation before having DBS. And we're going to do more events like this one. So in case you want to get in touch with us and learn from us about these therapies, just tune in on December 8th. There is a link there. You can register, and you will have access to this event. So before I start talking about pain, I think we just need to set the stage and say that Parkinson's is not just a motor disorder, is a very complex condition, as you know, with a lot of non-motor problems, which are actually even more common and more disabling sometimes than the motor problems. This is a list of such non-motor symptoms, and I highlighted here the problem with pain, which is quite common. How common is pain in Parkinson's? Well, you can have an idea from these graphs that basically it's very, very common, and it's one of the most common problems that Parkinson's patients may have. Obviously, there are little variations depending on the study and the populations under examination, but I don't think I need to convince you that pain is common. And this is becoming even more relevant during COVID and the lockdowns. This is the first French lockdown. This is a paper looking at what happened to Parkinson's patients during the first lockdown in France. And you can see that pain is actually number one as amongst the many problems that Parkinson's may cause, as the most common problem that worsened or developed during the lockdown. So I found this very important to mention to today's webinar. Pain is also a huge determinant of quality of life. This is an important study. They looked at the many factors that have an impact on patients' quality of life. And as you can see, the first is not tremor, it's not rigidity. Actually, these are quite low down the list here. The pain is the fourth in terms of contribution to quality of life. And as you see, the first one is mood. But you can also argue that low mood can also come from pain. So again, just to say that these non-motor problems that we're talking about are even more important than motor problems, especially if you want to look at quality of life influence. And not surprisingly, when you look at studies like this one, when patients are asked, so when we hear your voice, you will see that pain is number 4 amongst the most common problems reported in early PD groups. So people with Parkinson's with less than six years. So it's common, and it's common even early on. I don't know if you've ever seen this type of graph. This is a very complex picture showing how many problems, unfortunately, Parkinson's can cause. And you can see that these are motor up here, but also non-motor down here. And you can see again that the non-motor problems are way more common than the motor one. And more importantly, depending on where you are in the disease journey, you may have different type of problems. And you see pain here, as we discussed before, even in the early stage. So this is probably one of the most important slides I'm going to show you today. So at the end of the day, when doctors talk, they like to show graphs and report papers. But I wanted to give you a practical approach to pain, because as I always tell my patients, sometimes it's a matter of being educated so that you can educate other doctors, particularly your family doctors, your orthopedics, in case you get to see this specialist. So don't assume that simply because you're seeing a doctor, that doctor knows everything about you, about Parkinson's. And when it comes to pain, there are a number of issues that I've noticed over the years. So this is a very practical approach that I just developed for you. So it's a very simple approach, actually, but it's very important. So how do we approach pain? How you should approach pain and report pain to your neurologist if needed? The first and perhaps most important question is whether the pain is fluctuating, meaning that the pain is present sometimes and then it goes away. Because if it's not fluctuating, so let's say you have a pain that is there all the time, it's less likely to be related to Parkinson's, because pain in Parkinson's very often fluctuates. An example would be back pain. You might have back pain because of a disc, and the pain is there all the time. However, we should also recognize that sometimes having had Parkinson's for many years, especially at the beginning when it's not diagnosed, can also cause orthopedic problems that can be painful. So we say the Parkinson's has nothing to do with that, and maybe might be the right answer to give in terms of practical approach. But we may also need to realize that sometimes this particular painful condition coming from a bone problem, for instance, is being caused by Parkinson's. For instance, frozen shoulder. Many people, when they walk, don't swing their arms, especially at the beginning of the diagnosis, before taking a medication. And over time, that creates what I call rust in the joint, in the shoulder. And that causes, down the road, orthopedic problem of the shoulder, painful shoulder. Now we can say, okay, this is not fluctuating, has nothing to do with Parkinson's, sure. But clearly, having had Parkinson's for years has brought that on. Another situation, which is not that infrequent, is that pain is there, but it gets a little bit better when the medication kicks in, when levodopa kicks in. So this is usually when there's a combination of an orthopedic problem and Parkinson's. Another example, again, is the back pain. Patient has pain all the time because back pain is there. But then when levodopa kicks in, there's less muscle rigidity around the spine. And this is when the pain eases up a little bit and you have less pain, or the thresholds for pain changes. Sometimes people in the off state, when levodopa doesn't kick in or when it wears off, have more depressed mood or more anxiety. And that also makes pain worse. You feel more pain when you're depressed. And finally, yes, pain is fluctuating. And this is actually quite common. And this is clearly telling us that Parkinson's is playing a role here. So you have a pain, the medication kicks in, and the pain goes away. The medication wears off, and the pain comes back. So when you're dealing with this, you are dealing with either dystonia or rigidity, so motor problems caused by the disease, and that can be painful because muscles have pain receptors. And we'll talk about dystonia later. Actually, I found interesting that you wanted me to talk about dystonia and pain at the same time, because obviously there is a big connection. Or, which is also important to recognize, the pain can be fluctuating, and so responsive to levodopa, but it won't be associated to any clear motor abnormality. So you just perceive pain with nothing physical visible, then levodopa kicks in and the pain goes away. So this is what we call neuropathic pain, meaning that it's coming basically from inside the brain circuits that we all have. And this taps into something called non-motor fluctuations. Non-motor fluctuations are the fluctuations of non-motor problems. So here, when there's not enough levodopa, you may feel sad, you may feel anxious, you may feel pain. And then when the medication is in your system, you feel okay. If there is too much medication, you may also have the opposite effect, meaning that you may get manic, too happy, reckless. So this is an important point that we recognize more and more these days, called non-motor fluctuations. So clearly, because pain can be fluctuating, we need to briefly talk about motor fluctuations. Probably you're familiar with it. Are this on-off phenomena that people on levodopa might have? And these are just few studies, just to show you that this is quite common. And we usually say that all patients with Parkinson's disease will sooner or later develop motor complications, particularly motor fluctuations, usually 100% of patients by the 10th year of the disease. And these are just a few studies showing that more or less the percentage is actually around, between 40 to 80, 90, but much shorter than 10 years, 5-6 years. So when there are fluctuations, what you end up having are so-called off episodes. And off episodes are usually a motor manifestation, like tremor comes back, you can't walk, all of this, but also non-motor fluctuations, as we discussed already. And here there's a long list of problems that can come. And interestingly enough, in this particular publication, pain is not listed, but even pain can be a non-motor fluctuation during an off state. These are common problems. This is a survey from the Michael J. Fox Foundation, which found that many patients have actually more than 2 episodes of off during the day. So this is the problem of motor fluctuation is pretty common. There are different off episodes. You're probably familiar with wearing off, which is when the medication wears off before you're due to the next dose. Paradoxical fluctuation or unpredictable off, which is when you take a medication, it doesn't kick in. Problems at night, early morning off. And the ones related to pain are particularly these two: early morning akinesia and nocturnal akinesia, because often this is when you see pain, when you feel pain. In the morning when you wake up, you may have a painful cramp in your leg, or in the middle of the night, you might have pain in your legs. You might need to move your legs, which can be a result of something similar to restless leg syndrome. Nevertheless, this is still pain. It is a fluctuating pain, once again, and this will tell us how to treat the pain. I mentioned early morning problems. These are more and more common as the disease progresses, and this is the number of problems you may see in the morning, and pain is, of course, one of them. And usually pain in the morning is associated with the motor problem of dystonia. So in the morning, the patient wakes up with dystonia in the foot, most typically, and that is associated with pain. That's a very common situation. So how do we treat pain? And this is why it's important to have this general understanding of pain. Pain as related to Parkinson's, when it's fluctuating, partly related to Parkinson's or not related to Parkinson's, because depending on what type of pain you're dealing with, you need to use different systems, different approaches to treatment. The first things I need to say, and I put it there in as the first one, is to avoid painkillers. There is too much use of medications in Parkinson's when not needed. The patient is depressed, antidepressant. The patient doesn't sleep, medication for sleep. The patient has pain, painkiller. But most of the time, you just need to treat Parkinson's. And treating Parkinson's, you sleep better, mood is better, and pain is better. So often, especially family doctors, tend to give painkillers, which of course work, but they just cover the symptom. They don't really address the problem at its origin. And more importantly, especially nowadays, we have a problem with opioid medications. As you probably realize, these medications can cause addiction, and also they can cause constipation, which is already a problem in Parkinson's. So really, you don't have to start from painkillers. You need to start from treating Parkinson's, basically. And fluctuations, as I mentioned before, need to be treated because these will help pain, and there are different ways to treat fluctuations. We're going to talk a little bit about that. Avoid self-medicating yourself with levodopa. Obviously, nobody wants you to be in pain, and nobody wants to have pain. So what happens sometimes is that people with pain in the off state are so afraid of getting the pain back that tend to take more medications than needed. And this becomes an addiction to levodopa, which we call dopamine dysregulation syndrome, meaning that you take more levodopa even when not needed, and you end up having dyskinesias and other side effects of levodopa, like mania or excessive obesity. Obviously, this doesn't work all the time. So if it's not effective, you might use additional strategies. You might use botulinum toxin injections, Botox, Xeomin, Dysport. These are some of the brands of botulinum toxin available in Canada. And you can use them injecting the muscles, which is sore, because these are powerful muscle relaxants. I'll talk about this later. There are also medications specifically used for neuropathic pain, like gabapentin or Neurontin, pregabalin or Lyrica. So these are medications that have side effects. That's why we don't use as first agents, but they can be used on top of all the other approaches that I mentioned so far if pain is still a problem. Antidepressants sometimes are used to up the threshold for pain, so that with an antidepressant on board, maybe because there is also some mood issue, you feel less pain. Obviously, not all the time this approach works, and you might need to use a painkiller at some point. And this is particularly important when there is a coexisting musculoskeletal problem, back pain. Of course, if you have a protrusion of a disc or a frozen shoulder or arthritis somewhere else in the body, treating Parkinson's the best you can is not necessarily going to help entirely the pain. And this is when you want to go for painkillers, injections, and last but not least, physiotherapy, exercising, yoga, all the things that you may need to do to keep your joints in good shape. What drugs we use for Parkinson's? I don't want to give you too many details here because this is besides the scope of my presentation today. I'm pretty sure you're aware of levodopa and the medication we use together with levodopa to make it last longer. Levodopa in the brain becomes dopamine. But there are also medications that make the dopamine last more in the brain, like rasagiline, selegiline, or safinamide. There are dopamine agonists, which are medications that are similar to dopamine, and they stimulate the receptor without being dopamine. And these are pramipexole, ropinirole, rotigotine is the patch, and apomorphine. I'm going to say a few things about apomorphine, which is a new dopamine agonist available in Canada, which can be particularly useful in pain condition. Why so? Well, because apomorphine is a medication that kicks in very soon. So it's to be used in case of severe pain. You have a dystonia in your leg, a cramp in the morning when you wake up. The standard approach that you use takes longer to kick in. You might use these medications that bypass the gastrointestinal system, and that's why they're very fast. An important caveat here: apomorphine has nothing to do with morphine. Right? It's not morphine, the medication used for pain. Apomorphine is a medication for Parkinson's disease. It's not a generic formulation of morphine. It has nothing to do with it. So we have two types of apomorphine available in Canada. You may use the PenJet, which is an injection of apomorphine, as you see here in this patient of mine, injecting himself in his belly. And this is obviously not to be used all the time. This is something that kicks in 10, 15 minutes if needed. And another one available in Canada is this film. It's a strip that you can put under the tongue. And this is, again, apomorphine. There are different dosages. And they work. It works a little later than the subcutaneous formulation. Subcutaneous obviously involves the needle, kicks in faster, it's short lasting. The sublingual one takes a little longer to kick in, and it lasts a little longer. And then there's deep brain stimulation. I'm sure you know what it is. It's a brain pacemaker with electrodes stimulating different parts of the brain. And we can place the electrode in the thalamus to treat the tremor, but more importantly, either in the subthalamus or in the globus pallidus. These are two parts of the brain, here and here, that are used to treat the symptoms and the signs of Parkinson's. And if pain comes from fluctuations or dystonia, treating the disease with advanced therapies like subthalamus and globus pallidus DBS eventually results in better pain control. And remember this target here, globus pallidus, because we're going to talk about it later when we talk about dystonia. These are just studies showing the effect of subthalamic deep brain stimulation on the non-motor symptom scale that I mentioned earlier. This is what happened to people at baseline and 3 years later on medication alone. And this is what happened to people at baseline and 3 years after deep brain stimulation of the subthalamus. And you see here that depending on the different functions of the non-motor symptoms, there are different effects. Sleep improves, fatigue improves, and here, miscellaneous, which includes pain, improves, and improves with DBS more than with just medication. The same kind of study comparing two targets, the subthalamus that I mentioned before, but also the globus pallidus, and they basically do a pretty good job in improving certain non-motor problems, including pain. You probably heard about MRI-guided focused ultrasound neurosurgery, which is a very new technique using a number of ultrasound beams, actually more than 1,000. The patient's head is shaved, surrounded by water in a special helmet, which is inside the MRI machine. Water is used to cool the skin, but also to transmit this ultrasounds. The ultrasounds are shot all together and they're converging in one spot that is lesioned, is killed. And this can be done in the same targets that we use for deep brain stimulation. In this example here, this is the thalamus, which is used only for tremor, and this is the pallidus, which can be used also for the rest of Parkinsonian symptoms and signs, including pain. I just want to say that medications are effective, but they also come with some downsides. I don't know if you know about this, but excessive use of levodopa can cause neuropathy. And this is something that colleagues from Calgary for the first time found more than 10 years ago. They found a group of patients with Parkinson's and neuropathic signs, so neuropathy, nerves issue. And that can also be painful. And they found that in these patients, there was a reduction of vitamin B12, B6, So there was a reduction of vitamins that correlated with the amount of levodopa that these people were taking. It's now known that, especially if you use levodopa for many years at high doses, the body has a relative deficiency of vitamins, and particularly the B complex vitamins. And because of the lack of vitamin B, nerves suffer. And because of nerve suffering, which we call neuropathy, there can be pain. So part of the reason of the pain, especially neuropathic pain, can also come from excessive amount of levodopa used. Another problem I mentioned before is this addiction to levodopa that people with pain might have because they don't want to experience pain. They end up using more levodopa than needed. So I need you to hear what this patient of mine is saying now. When did you take your last dose of levodopa?
Right now.
Right now? So you take the medication every hour now. Do you take it also at night? Every hour, even in the middle of the night, you take it. And what happens if you don't take it?
It's stiffness and pain.
You have pain and stiffness. Before DBS, how many medications were you taking? Do you remember? Same thing. So as you heard, this woman is taking 1 tablet of levodopa every hour, around the clock. So 24 tablets a day. And she was doing the same thing before DBS. DBS hasn't helped here. Why? Because she has an addiction to levodopa. If she doesn't take it, she has pain. So this is something like a vicious circle. And people with addiction to levodopa are very difficult to treat because obviously they feel pain. Pain is real and they don't want to have pain. When you take the...
So I was on the patch.
The other problem that I want to mention is that, and this is instead what happens with dopamine agonists, is that dopamine agonists like pramipexole, the patch of rotigotine or ropinirole, they have a good effect on mood, sometimes too much. That's why people might also have impulse control disorders like gambling and such. But the other problem is that when you stop them, especially if you stop them too fast, there is again signs of addiction, which is in this case a withdrawal syndrome. And let's hear what this man has to say.
I was on the patch before I had my DBS surgery, and I wanted to come off the patch because I'd been reducing from 10 milligrams down to 4. And then a few weeks, about 3 months ago, I spoke to the doctors to get off the patch completely. As soon as I went off the patch, about 4 weeks later, when I was sort of off the agonist completely, I started to feel very apathetic. And I mentioned this as we were doing the work that we've been doing together.
So apathetic, low mood, but even more pain. So that's something else to keep into account. Okay, now let's change gear for a second and let's talk about dystonia. And as I mentioned already, there's a connection between pain and dystonia because dystonia can actually be painful, especially here. Look at this posture of the foot. That can be painful. Dystonia is a muscle contraction that causes twisting movement of the body, and that can be mobile or even fixed. In this case here, you have dystonia of one foot, dystonia of the fingers, but dystonia can affect the mouth, the tongue, the eyes. Dystonia can really affect any part of the body. And this it can also be generalized, but we usually see this in kids. And this is a definition of dystonia, which I just gave you. So this is a graph you saw before with all the motor and non-motor problems. Here, the dystonia is not necessarily reported because it's not very frequent, but it is relatively common in Parkinson's. And depending on what stage of the disease, you may have different type of dystonias that I'm going to show you in a second. You can have foot dystonia even before diagnosis. You can have fluctuating limb dystonia that can be painful. You can have fixed dystonia with postures, postural abnormalities. And let's have a look at these cases. So this is a man with no other problem other than this foot drop that you see in the picture, in the video. So when he walks, it basically slaps his foot on the ground. It looks like he can't lift his foot up. But if he runs, if he moves backwards, if he walks backwards, I mean, this problem with the foot goes away. So this is typical of dystonia. Dystonia is a motor pattern abnormality. So it's not weakness. is excessive muscle contraction, actually. And as you can see, this man is not weak, yet when he walks, his forefoot doesn't lift high enough. So this is the very early sign in this gentleman of Parkinson's disease. And this can happen. It can also be seen in early onset Parkinson's more often, even during the disease. And this is a patient with a mutation of a gene called Parkin. This is normal. Yeah. And this is what happens to him when he walks. This is again dystonia of his feet. They are tiptoeing basically, and he walks backwards and he improves. If he runs, he gets better too. This is now the connection with medications intake. You know that when medication kick in, you might have dyskinesias, which can present in different parts of the body. Dystonia, which is the topic of today's webinar, can affect more often the lower part of the body, especially in the off state, early in the morning, as we said before. In the advanced stage, it can affect the extremities, even the hand. And I'm going to show you a few pictures. So this is a man with dystonia of the face, the upper limb. Dystonia is so severe in this case that he cannot even talk. The good news here is that this responds to deep brain stimulation. And this is what happens when my colleague turns the DBS on, the dystonia goes away. So this is a typical situation of dystonia responsive to medications, but also to stimulation. This man has instead lower limb dystonia, which affects gait, and this is associated with some pain, some sense of urge to move, some restlessness. And this is something called biphasic dyskinesias. In this case, what happens is that the patient is not taking enough levodopa. Even though these are, in a way, dyskinesia kind of movement, taking more levodopa can help. So remember, when there are dyskinesias, the answer is not always to lower the medication. If there is a clear off dystonia, yes, you need to increase the medication. You may need to use apomorphine or change approach. But if there are these movements of the feet associated with some pain and restlessness, sometimes the strategy is the opposite, is to increase medication. And again, this is called biphasic dyskinesias. Dystonia can also be caused by levodopa. This is a series of patients collected by a colleague of mine from the States, Alberto Espay, and he identified a number of people that have this posture with the hand behind the back when they walk, and this is a dyskinesia basically. Technically it's a dystonia because it's a fixed posture, but it's caused by levodopa. These other men has dystonia when medication is off, affecting the face. You see the closure of the eye, the neck wants to bend forward, and this is what happens when the medication kicks in. He has a different type of dystonia. He's moving now. He has dyskinesias, but he still has moments when the eyes are closing, the head is going down. And see what happens when he touches his face. When he touches his face, he improves. There you go. This is something typical of dystonia that is called sensory trick. So people find that doing certain actions, the dystonia goes away. Not just changing the way they move, walking backwards, running, but also touching. So that's very typical of dystonia. It's called sensory trick. This is another patient I follow. This is actually an Italian patient. And he has postural abnormalities. Here, the dystonia is affecting the trunk. And you see here that he's leaning toward one side. This is called Pisa Tower syndrome, like the Pisa Tower. But this is present everywhere. You don't have to be Italian to have Pisa Tower syndrome. This can affect any person, unfortunately. And what else you see here is that he's bending forward when he walks. And this is something else that we call camptocormia, when the body wants to flex forward. And that is often a dystonia also. In the late stage of the disease, sometimes we see tiptoeing again, which is not responsive to medications, and knee flexion. These are other dystonias. we also see the air pillow sign, which is like having an invisible pillow, which is this neck rigidity that people argue can be also dystonia. And you have fixed deformities of the hand, of the feet. And this is again something that happens long term, especially when the treatment hasn't been established early enough. Why is it important to treat dystonia and to establish a treatment early enough? This is a man with Parkinson's, but he doesn't walk like a Parkinson's patient, as you can tell. He has stiff leg, he has spasticity, because he's been found to have a spinal cord injury, and the spinal cord injury that he had was caused by dystonia of the neck. So this man, for many years, wasn't diagnosed early enough. He had the dystonia of the neck, which turned out to be levodopa responsive, but because he wasn't diagnosed early enough and he wasn't receiving treatment early enough, he developed this compression of the spine that eventually resulted in a permanent damage of the spinal cord, and that's why he's walking with the spasticity. So this is probably the second other important slide I want to show you today, how we treat Parkinson's related dystonia. And again, this is just for you, very practical, yet very important. Again, you don't have to use necessarily something for dystonia. You need to treat Parkinson's. You need to treat Parkinson's fluctuations. Because as I said before, dystonia tend to be present when the medication is not in the system. However, I also told you that sometimes there are biphasic dyskinesias. When the feet are unknowing the patient, you feel you need to move, and they're also having some strange postures. But in that case, the treatment is giving more medication, or I also mentioned that sometimes excessive medication use can cause these involuntary movements with the hand going behind the back or affecting the face, the neck. And in this case, the strategy is the opposite. You need to treat dyskinesias, which means reducing medications, using amantadine. Sometimes you do all you can. Overall, Parkinson's is doing well, yet there is some pain because there are some spasms, either in the neck, in the eye, the foot. And this is where botulinum toxin can be beneficial, because Botox is a very powerful muscle relaxant. The effect tends to last 3 months, and you don't have to change all the medications. You just focally treat what's left to be treated. And even if botulinum toxin doesn't help, this is when you want to use advanced therapies, like the ones I mentioned before, the brain stimulation, or even a focused ultrasound if you want, or even infusion of levodopa, duodopa. So botulinum toxin, this is a man with Parkinson's, and this strange posture of his neck that we call retrocollis, this is another dystonia, and it can be painful. Again, dystonia and pain, again, are together. So how is the pain now?
It's pretty bad.
On a scale that goes from 0 to 10, how much is it?
In the mornings, it's in the 7 to 8 range.
And where is the pain?
It's basically, sometimes it's actually worse once.
So how is the pain now? Okay, so you heard this man has back pain caused clearly by the posture, by the dystonic movements of the neck. Levodopa doesn't help. And we inject it with botulinum toxin in the back. 500 in the right splenium. The cable is here. And you see here that you're going to hear some noise because I usually do injections using electromyography. So this tool tells us if we are in the right muscle, in the muscle that is active, that is contracting. And you hear the sound of the muscles now. Of DBS. This is the muscle. And the muscles stop working when I inject the toxin. Again, the muscle sound. This electric noise. With the tremor tone. So this is how an injection of botulinum toxin looks like.
After the injections, about 2 to 3 weeks after, I noticed quite a difference in the pain level. It was much lower than previously. It had been at pretty much the highest level, and I would say it's at least gone down half or more. The spasms pulling backwards mostly have certainly got much better in the time.
So as you can see, the posture has improved, is not pulling backwards anymore, and so is the pain. Remember, I mentioned globus pallidus pars interna, GPI. It can be very effective for dystonia. This man with Parkinsonism and dystonia is bending his knee. He also has the shuffling gait that sometimes people have, and this is after deep brain stimulation. So again, a good effect on dystonia. Now, what you see here is where we're going next. I wanted to end this presentation and have enough time for questions. And I want just to give you an idea of what we're doing right now, because we are now able to record the brain activity with this special deep brain stimulation device. And we are actually able to keep track of when dystonia happens. We know that when there is this type of activity, a very low frequency activity, we call theta activity, this is when there is dystonia in the body. And now we're keeping track of this activity, and we're trying to specifically target certain symptoms. This is tremor when there's a higher frequency around 10 hertz. This is beta when the patient is slow, and this is up here gamma when there are dyskinesias. So we are now recording the brain, and depending on the signals we record, we know what's happening to the patient. This is how it looks like. This is a patient with dystonia, actually, and we saw that there are particularly high peaks of this theta activity correlating to dystonia when we record from certain part of the brain, and we're using this information to stimulate the brain. So we're stimulating now using these contacts here, exactly the ones where there is more dystonia recorded, and this has been so far very successful. In conclusion, happy to take your questions, of course, and I'm really grateful to your Patients Association. I'm really happy, as I said already, to talk to patients and families about the disease, because they really need to be part of the team. We need to work together to make sure that Parkinson doesn't affect our lives too much. And your education is very important, because if you know what you're doing, what you're dealing with, you are actually educating your own doctors. You know what questions to ask, and also what information to give your doctors. For instance, next time you go to see your neurologist, if you have pain, you might tell them, I have pain and it gets better when levodopa kicks in. And this will help the neurologist manage your condition. These are the many people working with me at Toronto Western, which I'm really grateful to, because without them, I won't be able to do the many things I do to help Parkinson's patients. This is my Twitter handle in case you want to follow me on Twitter, my email in case you have additional follow-up questions later on. And don't forget, if you want to register online to attend our next webinar for patients on December 8th, we're happy to have you there. We've been usually hosting this webinar, receiving requests from basically everywhere in the world. And obviously we'd be happy to have you there too. And with this, again, thank you all for the invitation. And I want to now have a look at the chat box. I see there are 2 questions already. Very good. So don't be shy. Ask all the questions you want. I hope I'll have the answer. But actually, it's the same person asking the same one question. While I read this, feel free to ask others if you need me to answer questions. So the first question is there a progression of dystonia, particularly cases where dystonia presents first in the foot? Is there a relation between dystonia and regular cramping? Okay, so the first question about the progression, yes, dystonia changes over the years, but it depends. For instance, if the patient starts with foot dystonia, usually that goes away because that foot dystonia responds very well to levodopa. But people don't know that, and they may have this problem for many years before someone gives them levodopa, and then dystonia disappears. Yet that person might 10 years later have dystonia somewhere else in another part of the body. The other question is also a very good one. Is there a relationship between dystonia and regular cramping? Very often regular cramping, especially the one at night, especially the one early in the morning, is actually dystonia. And how do we know that? If you experience cramping, have a look at your foot. If I'm assuming the cramp is in your leg, see what's happening, because if you see that your foot is there normal, then it's not dystonia. But if together with cramps you see that the foot is twisting, it's moving, toes are going up or going down, that is dystonia. And that's an important information, because this can be treated in many different ways, including botulinum toxin injections. There is a question from Sandra saying, is there a chance to get this treatment in BC? Now, I don't know what treatment in particular you're referring to, so feel free to write in the chat what you're referring to, but I can tell you that in BC, all the treatment that I mentioned are available. I don't like to mention things that are not available in the country of the people I'm talking to, because I don't want to increase the frustration. I need you to be aware of what you can do, and all that you can do needs to be reachable. So all the treatments I mentioned are accessible to you. However, I know that in BC, unfortunately, to some extent, the problem is also in Ontario. There is an issue with wait time, particularly for duodopa or DBS. I know that there is years to wait. And this is a problem. Obviously, it's not doctor's fault. If anything, something that needs to change at the political level. But to answer the question, all I said is available to you. Different stories, how long it takes for you to get it. However, it's not always going for the most complicated therapy. There are many things that can be done in the meantime, optimizing medications, doing physiotherapy. So it's not just a matter of waiting 2 years until someone calls you to have DBS. There are many things to do in the meantime. Okay. Okay. In the meantime, Sandra Alexander is giving us an idea where she's living. But obviously there might be some commuting. And now I'm not familiar with your geography there, but obviously if you're not in Vancouver or in big centers, you might need to move to commute to get these therapies. Okay, Lynn Johnson is asking, what happens to me when I rush ahead? Meaning that you walk fast and faster. This is probably what you're talking about. This is called fascination. And it's basically the need to do shorter steps, progressively shorter steps. And in order to keep the balance and to move forward, you do them faster. So instead of doing big strides with with low cadence, you do short steps with high cadence. And this is something that usually responds to levodopa, but also physiotherapy, and needs to be treated, because very often leads to fall forward, because there's no other way to stop your body propulsion unless you land on a furniture or you fall on the ground. There's another question. I've just started on levodopa. I'm still having a foot dystonia, although not as severely as before. Is that a dosage issue? Yes, it is. I would say that clearly the fact that you're doing better on levodopa, it's good to hear, and it's also indicating that levodopa helps. Now, there are two things you can do. One way is to increase the amount of levodopa you're on, and this will help the dystonia. The other thing is that you keep the dose of levodopa the way it is, because you may have other problems that meanwhile have been taken care of, and there's nothing else left other than the foot dystonia. And you ask your neurologist about injections with botulinum toxin. So Botox injections or Dysport or Oxyomine, these are the 3 brands available in Canada, are pretty effective for foot dystonia and for pain. The issue is coverage. They're usually not covered for foot dystonia, so there is unfortunately sometimes the need to pay out of pocket. So if that's an issue, obviously increasing levodopa will work. So there's no reason to go and talk about botulinum toxin, but that's another approach. Okay, Sandra is now clarifying what she meant. The injections. Yes, the injections are definitely available in BC with botulinum toxin. Another question, can you explain biphasic dyskinesias again? Yes, absolutely, I'm happy to. And actually, biphasic dyskinesia is a very complex topic that many neurologists don't even get. And sometimes I made mistake also with biphasic dyskinesia patients. So we know that too much medication causes involuntary movements. Sometimes some involuntary movements are caused by not enough medication. And these are usually movements of the legs with some discomfort, some pain, some restlessness. And this is where more medications help. Why do we call this biphasic? It's very simple. As you know, Carla, the medication goes up and down. So there is a certain dose which is not enough. And when the medication is raising, you have the problem. And then when the medication finally reached the high level, the problem goes away. And then when the medication wears off again, you have again the same dosage, low dose causing the problem. So you have dyskinesia in the leg, then you feel good, and then dyskinesia comes back. Instead, we pick those dyskinesias, which are the commonest dyskinesias. You do well, the medication kicks in. An hour after, you have the dyskinesias when the medication is peaking, and then the dyskinesia goes away when the medication starts lowering. So that's the difference. Pick those dyskinesias, which are the most common one, caused by excessive medication. You are doing well, then you have dyskinesias, then dyskinesias go away, and then you wear off. Instead, in biphasic dyskinesias, you start with dyskinesias, then you do well, and you end with dyskinesia. So it's the exact opposite. Another question, is this talk on dystopia recorded? Okay, it's not dystopia. There's an important distinction to make. This is on dystonia. And my understanding, this webinar is being recorded. Okay, so a question on CBD oil. And this is a typical question that I get, especially in Canada, especially from BC. CBD is being used a lot in Parkinson's. Cannabis in general is being used a lot since the 80s. There have been pharmacological trials, no showing much. However, if there is something that CBD can help, is relaxing the muscles and also the pain. So yes, there is a reason to use CBD oil, at least as an attempt, if everything else fails. Don't expect miracles. It's not that effective as many people might argue. It might help sleep, anxiety, muscle stiffness, and therefore also pain. So certainly something to use. There's been, as I said already, a lot of research on this. It's been over 20 years now. Okay. I see that there are comments from Parkinson Society also. Okay. Yeah, how is gabapentin used as needed? So gabapentin is not one of those medications to use as needed. It's an anti-epileptic drug used for neuropathic pain. And it doesn't work that you take it and the pain goes away. It's not like Tylenol. You need to be on gabapentin. And if it doesn't work, you need to increase the dose. Gabapentin is usually taken 3 times a day. Instead, Lyrica, the other one, is to be taken twice a day. There is another question from Priscilla saying, my partner is in chronic hip pain. This was actually one of the first symptoms, meaning that hip pain, which was, hip pain was explored with MRIs, cortisone shot didn't work, nothing picked up on MRI, is still on chronic hip pain. We're going to visit neurologists next week. How to approach? Interestingly, Priscilla, I just saw a patient yesterday with the same problem. He presented with pain for years, and now he has clear Parkinson's. He started medications for Parkinson's, and the pain is still there. My hypothesis, and the same thing I'm telling you, is that probably Parkinson's was there for a while, and because of different way of walking, this has damaged the joint, maybe just a little bit, so that nothing really picks up on investigations, but the body is not moving in a symmetric fashion anyway, and that's causing a musculoskeletal pain. So what I will do, in your case, is taking care of Parkinson's first, the best possible way, and that pain might get a bit better. I will add physiotherapy on top, and then if there is still issue, this is when you start again doing the same thing you did, cortisone shot, orthopedic evaluation, because now it's not just one way to assess the problem. We are assessing the problem from different angles. We are taking care of Parkinson's, and now there's also other people coming on board to help with the pain. Brian saying, I have leg pain in the back of my knees. This is very severe sometimes. Sometimes one leg, next time other leg, and sometimes both legs, also pain in the crotch area. My balance is also very bad, but I never had a fall. I take gabapentin, but no other Parkinson's medication. because levodopa gives him very bad headaches. Okay, well, this pain in the back of your knee sounds like something that can respond to levodopa, especially if it gets worse towards the end of the day, in the middle of the night. It might be also something else. Sometimes people have cyst in the back of the knee area called a Baker's cyst, and they can get inflamed. But the way you describe it, the fact that it fluctuates, it's one leg one time, one leg the other, makes me believe that it's something related to Parkinson specifically. You took levodopa, so you might tell us if levodopa helped with the pain. If it did, but levodopa can be tolerated, I will look into different ways, either using the patch or of the dopamine agonist, injection of botulinum toxin, or even advanced therapies. But obviously, your case is a little difficult to comment more on because it's quite unusual to have headaches from levodopa. I would suggest also to try different formulation of levodopa. It's not just levocarb. In Canada, there is also Prolopa, there is Stalevo, so there are different things that your neurologist might try. Okay, so Priscilla is back saying, then diagnosed with Parkinson's. She's not sure. Okay, she's talking about the partner. Not sure if levodopa is helping. As I mentioned already, I had the feeling that levodopa could not do much about the type of pain, and there are also cognitive issues. Well, cognitive issues in this case, as obviously is related to Parkinson's in this particular case, but has nothing to do with the pain. I just repeat what I said before. Now that he's on therapy for Parkinson's and it's an established diagnosis, I will go back to the orthopedic specialist and see what else can be done. Okay, it's recorded on YouTube. Okay, Lynn Johnson is still saying, yes, I'm rushing ahead. Does mean I need more levodopa? I would say yes, it's something to try, but obviously it's important and safer that you discuss this with your neurologist. Don't do things yourself. It can be dangerous. We talked about the risk of being addicted to levodopa. Can you discuss the type of pain associated with Parkinson's? I often have an electrical type, tingling, stinging sensation at the base of my neck, upper neck, and I'm wondering if this is PD. Very good point, Penny, because usually the so-called neuropathic pain is burning, is tingling, is electrical feeling. So in Parkinson's, you might have basically two types of pain. One is caused by muscle cramping, which can be rigidity, dystonia, cramps, and that's the typical pain of a muscle cramp that we all experience in our life. Then there is a type of pain that is not related to muscle cramping or muscle activity. It is more, we'd say, neuropathic, meaning that it's an internal experience. And neuropathic pain tends to be electrical, with burning sensations, strange feelings. And you're right, that might be related to Parkinson's. Given the location, neck and upper back, I will also rule out a spine issue. And if there is no spine issue and the medications for Parkinson's don't help, neck injections with botulinum toxins are usually quite effective, even in these cases. There's another question. I get the occasional leg cramps during the night every 2 to 3 months. Is there any point in mentioning this to my neurologist? Can early reporting prevent worse problems? Very good point. So if something happens here and there, I don't think you need to first be worried about it. I will still mention it to your neurologist. It's important that the neurologist knows everything about you. So yes, go ahead. Unfortunately, reporting it early enough won't prevent anything. Unfortunately, we don't have any preventive measure. But if you report it, the neurologist will know that, and he might know that even in the future you develop insomnia or other related issues, then your case will be good to try extended formulation of levodopa at bedtime. Right now, it doesn't sound you need to have any therapy. I will have a tablet of levodopa next to your bed in case this cramps at night keeps you awake every now and then. You can take an extra tablet at bedtime when in bed, and you'll see that the cramp will go away and you'll fall asleep again. But if it's not that frequent, if it's not that bothersome, you don't have to do anything about it other than reporting it to your neurologist. Can forward slumping of the shoulder be corrected? Yes, with physiotherapy. There is nothing else there other than good physiotherapy. Does stretching and strengthening exercise help? It does. And actually, I can tell you more. To this point in our research, aerobic exercise is maybe not necessarily related to your question, but aerobic exercise is the only thing that has been shown to prevent disease, to reduce disease progression. And actually, we also know that if a sporty person develop Parkinson's disease, that Parkinson will be more benign than someone else that wasn't too much into exercising before. Same concept after the disease. If you haven't exercised before, exercise, do stretching. We mentioned yoga too, that will help. Okay, there's another question from the daughter of a patient saying, Mom has had Parkinson's for 12 years and showing signs of deterioration, specifically with her dyskinesias. She takes levodopa 5 times a day. Can you suggest any therapy? Cognitive issues and shuffling and dystonia is more prominent lately. Well, clearly there is a progression. And the fact that she has dyskinesias tells me that you can't increase the amount of each dose. In a situation like yours, you might lower the amount of levodopa and you can take it more often, but this can be less practical because it will be less than 3 hours interval. Or you can lower the amount of levodopa and use together with this low dose of levodopa medications that can extend the effect of levodopa, like entacapone, like safinamide, like selegiline or prasagiline. So there are medications that help levodopa. So you lower levodopa, but you give them you give levodopa extra support so the levodopa lasts in any case 3 hours and it won't cause dyskinesias. There are medications for dyskinesias like amantadine, although in your case amantadine can make cognition worse, so perhaps to be careful. Another one would be low dose, very low dose of a dopamine agonist, or also duodopa, levodopa infusion. Obviously, this is a situation that you need to discuss with your neurologist. Okay. Yeah, there's a question again about the shoulder and medications that can be used to help posture. Medications don't really do much to posture. Obviously, you need to have a good medical therapy on board so that you can exercise better. That's usually the goal. So with a good therapy for Parkinson's, then you can help yourself more. And you help yourself more with physiotherapy, with exercising, with Tai Chi, for instance, that can help posture, or with swimming. Swimming is very good for posture. So that's something else to add on top. Core rigidity is another important point that Susan is bringing up, and it's partially responsive to therapies. Even there, you might need to add additional treatments like physiotherapy or swimming. Okay, Robert is now saying, I have exercise-induced dystonia in my left toes and foot that predates use of levodopa. Does the fact that this is exercise-induced have any particular implication for therapy? Excellent question, Robert. This is something you need to tell your neurologist, because usually exercise-induced dystonia is seen in certain type of genetic Parkinson's. In early onset Parkinson's, I will imagine that you are on the young side. It's probably something that started in your 40s or even earlier. You might tell us what type of Parkinson's you got. The therapy is basically the same. There are other conditions where there is exercise-induced dystonia and they respond to a ketogenic diet. To my knowledge, this hasn't been proven to be effective in Parkinson's patients when there is exercise-induced dystonia. But in few words, what you have is extremely rare, but well-recognized, so you should tell your neurologist. Can Dr. Fasano's emails be put up again? I'm gonna type it in the chat box so that you get it, but please don't send me 10,000 emails because I'm still replying to the ones I got last year. No, I'm joking, but be careful with emailing. Okay. My mother uses a TENS machine to ease some leg and hip pain. She finds that it helps. What is your opinion on this? It does help because TENS relaxes the muscle. Exactly like massage therapy helps. I would not do chiropractor because they can be quite aggressive. TENS helps, massage helps, anything that relaxes the muscle. A warm bath helps, CBD oil helps, anything that relaxes you helps. What's the max number of doses? 125 daily. So this is levocarb. there is no max dose, really. Too much causes problems. So at some point, you know when it's too much. I've met patients that took up to 25, 30 tablets a day because it was needed. Usually in these cases, we do deep brain stimulation so that we can lower the amount of medication taken. Okay, do you have any suggestion for someone who's experiencing nausea with all the add-ons to levodopa? I tried them all. Well, nausea is usually responsive to domperidone. I don't know if you tried that. If it's not helping, you can use extra doses of carbidopa. It's difficult to have it. Your neurologist should should request it because it's not available in pharmacies. But if you request, you might have it. So you add extra carbidopa. But the first step will be domperidone. Donna Smith is saying, I have terrible sciatica and constant foot tingling, burning. I've tried every pain medication, botox and steroid shots, and nothing helps. I had DBS in 2019. My neck is always stiff. Is it possible my levodopa is causing part of the problem? I take it 4 times a day. Donna, I think that you have a disc protrusion. You need to be seen by an orthopedic surgeon. Probably you might need to have either physiotherapy targeted for spine issues or even a surgical intervention to your spine. Having had DBS, having a spine MRI might be tricky. So I will do an EMG and of your legs, and I will see a neurosurgeon or orthopedic surgeon to see whether something can be done to your spine to improve the sciatica. No surprise that all you've done so far doesn't help, because probably there's a compression caused by a disc protrusion. Neck stiffness, it's probably coming from Parkinson's, but also from your spine. If you have sciatica, it's also possible that you have some disc protrusion in your neck. I don't know whether you have bad posture, if you spend a lot of your time working seating, but I see from what you're writing a lot of orthopedic problems, and levodopa is probably not causing any harm, nor is DBS. Robert, I'm 68 and diagnosed a year ago. Genetic testing is negative. I would say yes. When you diagnose so late, very rarely there is a genetic component. Oh yeah, you are the one with the exercise-induced dystonia. Interesting. You have an exercise-induced dystonia that started when you were 66. Interesting, very interesting. I wonder whether they tested also the glucose transport, even though you're too old for that. Yeah, clearly we're still learning, because I never heard of a patient with your age having this problem. Usually it happens much earlier. Yet all I told you before still applies in terms of therapy. Deborah is saying that domperidone didn't help. Try with extra carbidopa then, but you need to ask your neurologist.
Dr.
Okay. Yeah.
Dr. Fasano, we are over almost 10 minutes. Are you okay with answering?
Yeah, actually, I have a meeting with a student that is late. Unfortunately, I need to, I'll answer the last questions, and then unfortunately I gotta go. But like I said, my email is there, so if I don't happen to answer all the questions, please email me. But I'm happy that I happen to answer many questions. Happy that I hope that you found this useful. Let me answer this last few questions. My dad has DBS surgery, which has helped to prevent total freezing episode. However, is now having more period of hallucinating. Symptom has been decreased. There are some days where he's able to get out of bed and others where he's mostly in bed. Has hip pain and neck stiffness. Well, he needs to be treated. The pain, I wonder whether sometimes this is caused by the reduction of Cinemet, but I see why Cinemet was reduced, because the priority here is to improve the hallucination. Sometimes to improve the hallucination, there are medications specifically used for hallucination, like quetiapine or clozapine. So your dad can use one of these medications to take care of the hallucination so that your neurologist can increase Cinemet again. Magnesium for exercise-induced dystonia. You might try. Why not? Yes, it's a muscle and neuronal stabilizer. Try not to take too much because it can affect your heart, but it can also help your constipation if you have any. So you can try and see what happens. Parkinson gene FBX07. Yes, it causes a very specific type of Parkinsonism, which is not necessarily responsive to levodopa. You may need to talk about it with your neurologist. Okay, and the rest I think are thank you notes. Very good. Thank you all. I'm really happy that this will well received. Happy for to also receive these hearts. Well, let's stay in touch, and maybe next time we'll see in person. Thank you all for the invitation, and don't forget to exercise.
Dr. Fasano, thank you so much for such an informative presentation. I don't know if you're still there, maybe you're gone. Thank you all for all of your questions and for attending. And oh, okay, you are still there.
I'm still there. Yeah, I wanted to take a screenshot because it's really nice to see all this thank yous, which really gives me motivation to continue with what I'm doing.
Yeah, I have to say this was such an impressive and informative presentation, and you answered so many questions. So thank you so much. And
anytime.
Thank you everyone for attending, and we'll see you at the next webinar.
Bye-bye.